So, I was in Spain, and this woman said she had plantar fasciitis on her heel. So I said, okay. So I took a quick look. Took me about 10 seconds, and the next day she said to me, "The pain's completely gone." I said, "Yeah." So she said, "You didn't do anything." I said, "I did do something." So I treated it. She said, "No, you didn't. You just examined me." I said, "No, but I can't split the two. You can't split one from the other." So when I left, she was absolutely 100%. She said, and she was she didn't know. She expects some sort of ceremony to do with, and this is what happens in treatment. We actually end up in a ritual. Hence, we learn techniques, because those who teach the techniques, like in religion, it's a ritual, and this is why I still didn't teach technique, because the technique, he saw as the tail of a dog. So he was afraid the tail would wag the dog rather than the dog wagging the tail. And that's where we are today. The tail is wagging the dog. If you look at the back of all the osteopathic journals, all the osteopathic magazines, under CPD, it's all technique. Cranial techniques, visceral techniques, myofascial techniques, all of it's technique. There's very little clinical methods. There's very little of anything else. So if we were as good as the osteopaths used to be 100 years ago, according to McKone's books, 700 pages and 12 pages on musculoskeletal, then we'd be treating ear infections, sore throats, headaches as standard. And people wouldn't see us. So immediately I see someone abroad, or when I was to speak in Spain, someone says, "Oh, osteopath back pain."
Yeah, everyone says that, don't they?
It's just nonsense, absolute nonsense. But we keep pursuing it, and we're pursuing it to our downfall. So it's like confusing physiotherapy with osteopathy. The more we go and see physios and look at what they do, the worse we get, because it's a contamination process. Rather than going forward with what we're supposed to be doing, we're trying to pick up from other people, and we don't even know what we're supposed to be doing. So it becomes an identity crisis in the end of it all. That's why the whole profession's the way it is. So again, for example, going back to palpation, if you want to the only way you become really good at palpation is to actively deepen the experience of palpating. Because we talk about people having experience in things. What no one teaches is how to accelerate that experience process, and that's what we do abroad. So to say just to touch something is not palpation, because two cars can touch in a car park. So the contact process is not the palpation, and that's where the problem lies.
Yeah, no, I can see that. I can see the point you're making, because people, I think, they end up getting quite. They sort of. I know that when we're learning, there's a lot of students that just put their hands on and think, yeah, I can feel it, and just completely agree and don't actually think about what's actually there.
Well, I think I wouldn't blame the students ever. It's always the tutors. No, I think you think you palpate by touching something. That's the trap. You don't palpate by touching. The only way you can perceive something is through meaning, not physical contact. So if I showed you something like a pen, you know it's a pen because it means something to you. You can write with it. But if I took a pen to an indigenous population in Borneo in the jungle somewhere and showed them a nice Mont Blanc pen, they wouldn't see it the same way you see it.
It's a perception thing as well, isn't it?
In a way, but it's still about meaning. We tend to think of perception as some neurophysiological process of the image being sent to the brain, which is again nonsense, because it pacifies the whole process. So all physiology books treat the person as a dead passive object, as a recipient or a stimulant. There's a two-way traffic, which in reality only happens when you're dealing with dead machines, not living people. So that's what's undermining our ability to practice or be effective in practice, because we've already downsized ourselves already into this passive process, and so therefore we're ineffective. So when I do something like that with the patient very quickly, what they miss is the ritual. They think they're getting their money's worth because of the ritual of treatment. So if you did a good 45 minutes soft tissue work, they'll feel like, God, they've got a good treatment, but you maybe walk out with the same pain.
Yeah.
And we don't go to the dentist and say, can I have more time, please? You want to get out of there.
That's true. That's very true.
But you don't say, oh, well, I paid for 45 minutes, can you continue drilling? And that's where we go wrong. We seem to think all the time that it's about the treatment. It's not. The most important thing in osteopathy is the diagnosis. You spend more time diagnosing, less time treating, you have a busy practice.
Yeah, that is true, actually.
Because I've trained my patients nicely to know how I treat. So to make a phone call just now, that phone call I made just now to BT, to the top guys in BT about his son just get his knee yesterday. So he knows that I'll tell him what to do and it'll be fine. So if I can actually see it, he knows if he describes things to me, I'll begin to see it. And then cross-questioning him on the phone. And he knows me for years, so he knows how to deliver information to me, which is how you should be training your patients. The idea of osteopathy, again, is to educate your patients, not to treat them. So actually they know how. I've got patients say to me, well, I hurt my knee, but I thought it through, and a week or two before that, my hip on the same side was aching because of gardening, so my knee pain came up for no reason. I was thinking it's my hip. And that's what my patients would tell me that. Because I've taught them to think osteopathically. Think in context of time, think in context of events, emotional or physical, doesn't matter. And that's what we don't. What we tend to do is we tend to diagnose structurally, which leaves it short all the time. What we should be doing is diagnosing biochemically. So, if, for example, I say, could you write me an essay on the biochemistry of manipulation? People sort of go, oh, what? Because manipulation is seen as mechanical, which is wrong. I mean, for example, if I said, what would be the biochemical reaction to an HVT to the L45? Any idea?
Black faces.
Yeah. No idea.
Well, that's what I'm saying. You see, because it shows us it's a complete dogma. All we think about is the facets, but actually what happens is the reason why a patient has a pain is usually because of an acid-base shift towards the acid. So when you the contraction that's caused by acidity ends up stimulating nociceptors, blah blah blah. So therefore, your HVT to unlock a joint will cause a reflex action, which will drain towards more alkaline. Does that make sense?
Yeah, no, definitely.
And no one's ever said that to you, though, have they?
No. We just sort of get told, like, do this, it'll help. Not sort of the background behind how...
What about the biochemistry of soft tissue? Think of it from a biochemistry point of view. What would happen to acid? What would happen to an acid? We're basically talking an acid-base system. So if somebody comes in with a stiff muscle, do you think it's going to be more acidic or more alkaline?
Acid.
Yeah, it'd be more acid because the blood supply will slow down, build up of acid waste products like lactate and all the rest of it, and that's what causes the discomfort. So soft tissue work, but all they ever talk about in soft tissue work is a gamma gain system or neural pathways, which is just silly. So if you've got a very, very stiff neck, and I say stiff neck, I don't mean stiff muscles, I mean stiff neck. I've got to explain myself to osteopaths. When I say examine the neck, they go straight for the erector spine in the joints. If I say to a doctor, examine the neck, they get their hands out, start feeling for the glands. Like submandibular lymph glands, observing tracheal deviation or stenomastoid. But osteopaths go, just start manipulating, it's like ridiculous. Right. Yeah, if someone has a stiff neck, what do you think is going to happen to the mucous membranes of the throat?
They probably just sort of get, blocked up or get that.
Well, acid again.
Yeah.
You get acid because it's all about circulation. If you slow circulation down, look, if you slow a stream down, it becomes more acidic. The water becomes more acidic. There's always that. I remember conservationists talking about if you get bushes or a tree overhanging over a slow-running stream area, you get all this moss arising. It becomes more acidic. And mucous membrane is exactly the same. So and then of course, bacteria loves an acidic environment. So that's how you get sore throat. So what the doctors do is give you if they want to, antibiotics, whatever, because of the bacteria. But if you just clear the system by cervical spine traction, by soft tissue work, because the muscles are bold of the neck, then the acidity shifts. And therefore you change the environment becomes hostile to bacteria rather than supporting it. Or does that make sense?
Yeah, see, I never thought you could, I've never thought that you could sort of, don't know whether treat's the right word, but help with a cold. Like we've always been sort of taught that. I feel that we've always been taught that you do more musculoskeletal and muscles and
but they don't talk in terms of biochemistry and pathology in relation to that.
They tell us that you think of the body as a whole, but
but not.
But yeah.
That's what I'm saying. It becomes a contradiction.
Mm.
So if you look at the biochemistry of manipulation, it's a biochemistry of disease. So we tend not to do that. We tend to think of things in purely mechanical sense, which is just nonsense. Which is what the physiotherapists do. So, and if you think of things in a mechanical sense, flexion, extension, side bending, rotation, then what's the throat got to do with it? And that's where the problem lies, because no one's body or tissue in the body is in a straight line. So the moment you start doing flexion, extension, side bending, rotation, you end up with confused results because you're cutting across tissue planes, because nothing's in a straight line. Nothing falls. You're cutting through skin, muscle, bone as the person begins to flex in that line. And that's why it's confusing. So what osteopaths tend to do is make up diagnosis, and I use the word make up loudly, diagnosis to fit certain criteria. So if somebody says, oh well, someone bends forward 10 degrees and it gets clearer, and then they carry on and start hurting again, it could be this, and this. And I'm saying, well, no, that's just nonsense. It's actually the diagnosis. It's back to front. It's the action causing the diagnosis to happen. Does that make sense? Because whatever the problem is, it's not going to be a straight line. Because the diagnosis is either in one tissue, or, which is normally the case, it's multiple tissues to varying degrees. So like you sprained your knee, or you hit your knee, or really hard against something. All tissues are going to be involved, but to varying degrees because of the individual person.
Yeah.
So the moment you start doing flexion extension, the examination process, it's that flexion extension that's causing the diagnosis to be a certain phenomenon, rather than the diagnosis itself. So you end up diagnosing because of flexion extension, medial lateral gapping, traction, blah blah blah.
Yeah.
That gives you signs which you've already catalogued. So every patient is now the diagnosis of most patients is the result of what I call lowest common denominator, which are these are the common findings in this disorder. It reduces the patient to lowest common denominator. Same as cranial. If you're looking at CSF movement or flexion extension, or vasovagal movement of ventricles, because that's a theory, you then apply that theory to look through to every patient, and that becomes a lowest common denominator again. So every theory, the word theory comes from theoria, which means to see or behold. So you're seeing before the patient, because you have a theory. Does that make sense?
Yeah.
Rather than, and this is what AT still didn't do, because he was always, people always said, oh, he has no theory, and that's why it was always confusing. So what he was doing, rather than theory testing, which is what we do all the time, even cranial visceral structure doesn't matter, we're testing a theory because we have an idea, okay? Rather than doing that, what AT still did, he would build a theory out of the experience of the patient, not test a theory.
Yeah.
And to build that theory wasn't a case of, being open-minded. And this is where people go wrong, it's about being attentive to something. So by deepening personal experience, which is what he did, he would be attentive to things, not go in with a theory. So he wasn't open-minded. And that's where people make errors, and also people think it's chaos if you don't have a theory. Because it's the worst. It's like I always use the example of a forest. I think people tend to like that. It's like seeing a forest and thinking that's a complete mess. I'm going to tidy it up, and then cutting everything to flexion extension specifications, making the trees square.
Make it fit.
Make it fit, yeah, and trying to straighten out the branches.
When it's just not in school.
It's just nonsense. That's how it is, exactly. So. When you walk through a forest, you never make a straight line. You have to move with the forest.
Absolutely.
With the terrain and what's there. So I'm saying that our examination process should be with the terrain of the patient. And what we then tend to do is build up an idea as we're going through the forest. And you have to be attentive. So it's not a case of just running around. And if you try to run through a forest in a straight line, how long do you think you're going to last?
Not very long.
Right. So that's what we do to our patients. All the time. The standing exam is the worst thing ever. It was introduced in the 1970s.
It's a modern.
Yeah. The standing exam is to reduce the potential chaos of patients' findings. which is nonsense. Rather than go through, so we're drilling a path straight to the middle of the forest, and then one at right angles to it, and taking that as being the way the forest expresses itself, the findings from that, which again is nonsense. So that's why osteopaths have a really confused situation, because they're taking stuff from physical therapy. I mean, what physiotherapists now do, as I understand it from my patients, is they spend their time drawing the patient with a clipboard. And that's what we've been doing, which is just silly, because no one stands still like that, ever. Not even in a bus stop, we don't stand still like that, an anatomical position.
Exactly.
We never stop moving. So the whole thing becomes, and that's why when you diagnose, you're diagnosing the movement, not the patient. You're diagnosing the results of the patient's movements, which again are artificial.
Yeah.
Rather than actually examining the patient, or observing and then examining the patient. That's what tends to happen. So that's why a lot of people get confused. So, other than getting you examined and getting out here, this is why we started up the whole Facebook page and putting all these recordings on, so people can listen and have thoughts and make contributions towards that. So, what's the next patient talk about? Any questions?
No, I just think it's quite interesting though. Really, it's because it feels very structured.
But that's make you feel. But that gives you safety.
Yeah, and I think it does for the patients as well.
Yeah.
That's why I remember you were saying some patients were sort of not happy that you didn't have sort of a structure, and I think that's why people feel a bit. They used to. I know that years ago, when I first heard about osteopathy, people were uneasy about it because it had no structure.
It did.
Well,
the structure was the thinking of the osteopath, but what it didn't have is this idealism, or which we see as being safe and stable. What's stable about nature? When does it ever repeat itself twice? So we have this idol of stability in our world. It's an idol. So we're trying to organise it. We should be organising it on a philosophical foundation, not on a physiological foundation.
Yeah.
Because that's where the difference lies. So it's this absolute structure that's the strangling osteopathy. In fact, it was Aristotle that said, when does security become a prison? We've trapped ourselves in what we've created, and we can't get out.
Yeah.
So that's what happens. So osteopathy by its structuralization of all forms, it's become less and less effective. It's like people talking of the mechanical pain or organic pain. What's that supposed to mean? Just make any sense to me. Realistically, it's all organic. It can't be mechanical. How can you split one from the other?
It's all interlinked, and everything's. It's just.
Well, I was doing something talk about connections the other day, talking to somebody and saying, actually, the problem is thinking that everything's interlinked or connected. That's where the problem lies.
Yeah.
Because nothing. In fact, we did some video in Spain of me trying to explain the difference between interlinked and connected and wholeness.
Right.
A car or a motorbike is formed from outside in. Parts are brought together to finish with the whole, which is the motorbike. A flower forms from inside out and is always a whole at all times.
That's true.
When's a small plant or a big plant not a whole?
You don't get a big plant and make a small plant.
Yeah, exactly. So you don't take parts from something and put it together. So everything organic comes from inside out. Everything mechanical or dead comes from outside in.
Okay.
So a motorbike is connected parts, interlinked. But an organism has never been in that position.
That is so true. I've never thought of it like that, actually.
I mean, nobody gave me my arm
to
attach to my body. But that's it, isn't it?
Yeah, absolutely.
That's how we're thinking all the time. And again, what that does is, it breaks down your ability to treat. Because of your mode of consciousness. That's the trick. That's the power of osteopathy, the mode of consciousness, not the hands. So when I see osteopaths say, you take photographs of the hands. In fact, there's a new book out on osteopathy, and it just shows pictures of people's hands. Like, what's that about? That's the end. It's too late. So the wholeness is not a thing. Once you make wholeness a thing, then it has to be relative to something else, which makes it not whole anymore. It can't be the wholeness because there's something else. So you can't have wholeness and, because then it can't be whole, can it? Because it would include the thing you're anding as well. But when you talk about interlink, like the hips attached to the low back or the knees attached to the hip, that's a mechanical phenomenon that philosophically is treating the patient as dead. because to think like that, you can't be living. A motorbike is not living. A car is not living. So philosophically, we treat the patient as dead, and then we're trying to treat the patient. Well, it's very hard to treat dead people. We can't do it. So all our actions are based on death. So if we examine the patient flex extension side bending, and we're testing with our hand, we do that by observation first, and then do the same thing with our hands. We're forcing upon the forest a straight line, and we're taking readings from that straight line as being the genuine representation of the forest, which it isn't, because it's a false, it's an imposed phenomenon. And if you think like that, it's the same thing, because thinking and doing are the same things, but to one's less extent than the other one. But thinking is an activity. You have to be active to think. You can't be dead and think. It doesn't make any sense. So while you're alive, which is an activity, you are thinking. Now, I always say, there's two extremes to playing tennis. There's thinking about playing tennis, and then there's playing tennis. They're actually the same thing, but one's a more gesturing phenomenon into the world, which is the activity of actually playing.
Okay, yeah, no, that makes sense.
So there's no thinking and doing. There's doing, but to varying degrees of expression and intensity.
Yeah.
Does that make sense?
Because even thinking about it, you're doing it, but in your head.
Yeah.
But then when you take that further and actually...
It's the same expression. I want to go and buy a sandwich. I'm thinking to myself. Well, that's part of the doing. It's just when you get up to go and get the sandwich, it's the same. It's still a doing, but a greater gesturing of the doing.
Yeah.
So probably the other problem is thinking about mind in our head. That's the other problem. I was going to do something on that on Facebook. We always think we think in our heads. We don't. Thinking is a process of is an activity, and we're always active.
Yeah.
It's just an intensification of an activity. So it's like William James said, it's a bit like a bird flying. Every now and then it will land on a branch. That's where we're conscious of ourselves thinking about something. We carry on again. It's an activity. So the reason why we think in our heads is because all our senses other than touch are above the bottom lip. So that's where we're most aware of ourselves, is around our head. So thinking is a total body phenomenon. But we're aware of ourselves thinking only in one part. Because of where our senses are. And the reason why the senses are where they are is because of the mouth, not because of the brain. The brain overlooks the mouth. The mouth is the entrance to the body. What do babies do when they grab something? Newborn babies? Stick it straight in their mouth. So the hand and the mouth develop the brain. Well, they actually the hand, the eye, and the mouth develop the brain. The brain develops. It's not developed at birth. So the activity of seeing, handling, hearing, taste, it's the whole phenomenon develops the brain. Okay. The brain comes last. The baby can walk around before the brain's developed. But we've got this obsession with the brain. So really, everything we do in philosophy, psychology and science is all back to front. Because if the brain develops over time, from a toddler up to whatever age, then that's the last thing to develop. But we've been doing things since birth. A 4 or 5 year old can speak to you, but the brain still hasn't fully developed. So the brain is the last thing to develop. But what develops before that, the primary system is a musculoskeletal system. That drives. So when our brains do develop, we then ascribe, or I suppose ascribe is the best term, our behaviour to our brain. It's back to front. The behaviour's been happening before the brain's developed.
Yeah.
Does that make sense?
Yeah.
Well before. So basically what happens, the brain's a generator of power. This is what A.T. Still said. It's a massive battery. As the battery develops through time, with the child getting older and older, the ability to progress, the power to progress becomes more and more and more and more.
Okay, yeah, that makes sense.
So language is through movement, for example. Thinking is a movement process. Not in our heads as an object of containment. A bucket's an object of containment. A car's an object of containment.
Yeah.
So even that process, we think of any behavioural problem as being a brain problem. It's not. It's a movement problem.
Yeah, no, I can see where you're coming from actually.
We're obsessed with the brain thing because of religion. The mind used to be the soul.
Yeah.
So for me to go around, which is my next project, is to slating off mindfulness, which is really easy to pull to pieces. I made a statement about how mindfulness is going to make a big contribution towards our ill health. because it's the mind again, which is obsessed with this phenomenon all the time. And trying to tell people the mind doesn't exist. You know, when Aristotle spoke about soul, body and soul, he wasn't talking about a religious soul. He was referring to soul as the ability to express yourself into the world, which is a non-physical phenomenon. It's both gesturing.
Yeah.
So happiness could be seen as an activity of soul, but you express it as the body.
Yeah.
It's not behind the body, not in the body. It's the activity of.
Because people get lost in their own mind, but if people sit in a room all day, they're not moving, and it goes backwards instead of their mind causing them to not move around and.
Because what we tend to do is re-represent the world rather than present the world to ourselves. Because by the time we've experienced something and become aware of that experience, and then give a name to something, the event's actually finished. So we take the finished product, give it a name. So now we're re-representing it, not the thing in itself, not as it became. A bit like cheesecake, right? Cheesecake gives you no indication of the contents, what made it up. So the cheesecake is the end product.
Yeah.
So the activity of making a cheesecake is the becoming of the cheesecake from all the parts, with flour, water, eggs coming into it. So the end product is cheesecake. So we say, right, because we've got this end product, it's like saying that is the cheesecake, but actually it indicates nothing of what's happened before that. So we're always looking at the end. So now we're re-representing eggs, milk and flour. We're re-representing it as cheesecake because it's completely it's the end. So everything, it's like you go to see a show, you don't see an advert for the show saying, let's say we see, I don't know, King Lear at the theatre. We don't say re-representing Shakespeare's King Lear, we say presenting Shakespeare's King Lear. So what we tend to do is when it comes to arts, we tend to say the present, we're presenting something. When it comes to science, we actually take the experience, re-represent it in forms of flexed extensions, and does that make sense?
Yeah.
We don't see the thing for what it is. We put it into this ordered phenomenon. Numbers, weight, all forms of magnitude. So we're re-representing the experience of the patient in a form of flexed extension side bending. Does that make sense now? So rather than just look at the patient and say, actually, I feel that, it's not allowed. It has to be a clinical re-representation.
It's almost got to fit into a table and a list.
Yeah, absolutely. So that table, that list has been made well before the patient arrives.
Yeah, and everyone has got to somehow fit into that table and be like almost, I don't know, just fit perfectly. And if
that's what's termed the lowest common denominator. So we're reducing every single patient to a lowest common denominator.
Yeah, sort of like crossing off things as you.
Which is the result of flexed extension, side bending, whatever. And even if you're thinking about flexed extension, if you're palpating someone's head or head, it's going to be cranial, and trying to get expansion, contraction, and then flexed extension, you're still working on a theory which lowers the patient to a common denominator.
Yeah.
Does that make sense? So the ability to go to examine a patient without doing that is the skill. That's where the power lies. So
How do you go about it?
Well, the first thing you do is don't have an open mind, because that's nothing at all. Goethe said it's nothing. An open mind is no mind at all. What you do is have an attentive mind to catching yourself in the act of palpating. How am I palpating this patient? Not what am I palpating? Because the what could be C1, C2. Oh, I can feel that. Okay, whatever. How am I doing it? What am I feeling while I'm palpating that patient? So it's as if you come back a bit to yourself.
Yeah.
You catch yourself. It's a bit like catching yourself in the act. Let's say you're going to throw a ball up in the air. Be attentive to the act of throwing rather than the ball being thrown.
Yeah, okay. So instead of like noticing the ball when it's in the air and going across the park or whatever, you sort of notice yourself lifting your arm and
that's it.
Releasing it. And
yeah. So that by doing that and relaxing, you build on your efficiency to throw the ball should become better and better.
Yeah, because you've noticed how you do it and you think, well, that bit, and then you sort of can tweak it according.
Yeah, as you feel it.
Yeah, as you feel it.
Yeah, and that's catching yourself in the act. So next time you're palpating a patient, be aware of yourself doing the palpate. Don't worry about sending your fingers. Just feel yourself doing it. Well, that deepens the experience much quicker. my Polish students a few years ago, we were trying to work out a way of how science works in reality, and he came up with the idea of a tennis ball, throwing a tennis ball against the wall and catching it. So if the activity is to throw the tennis ball, it bounces off the wall and you catch it.
Yeah.
So what science does, science is objective. You're not there. That's what they're trying to do.
Yeah.
Keep it objective. So what science says is, you haven't thrown the ball. The ball's only come back to you. It cancels out you throwing, but only pays attention to the ball coming to you.
Yeah.
Does that make sense? Because it sees you throwing the ball as being subjective, but the ball coming back to you as being object. It's the object. You're catching the object.
Yeah.
So science ignores you as a scientist. So basically, all that we do in science is a reflection of our activities as scientists.
Yes.
Does that make sense? Same as osteopathy. What we palpate, what we feel, and how we examine is a reflection of our own activities.
Like as a chemist, you'd put chemicals together, mix it, and you would record what happens, but you haven't taken the
scientist in consideration, what scientists did.
The fact that you've stirred it and added it in, and
which is the activity of doing science. Exactly.
You can't. Something has to do it for it to occur.
But then in science, the doing, it's like when you write up your notes in science, in chemistry, for example, you always write it in the third person.
You do, yeah.
A test tube was taken. Not I took the test tube and had a crap day today.
Yeah.
That sort of thing.
So I dropped it as the second one.
Yeah, exactly. So, but you think by taking the same test tube every day, you do it the same way. It's nonsense. I had really bad news this weekend, blah, blah, blah. I took this test tube and I filled it up with so-and-so. And that makes it, that's the activity of doing science. But we don't do that. We just make it all clinically clean.
Yeah.
How much did you weigh? What did you mix it with? Yeah, it's fine, but who's doing it?
Yeah.
So it's a bit like, let's make another example. Making a sandwich. All we tend to look at is the end product. Yeah. The sandwich made. So what I'm trying to do is say, look, when we look at the activity of making the sandwich, getting the bread out of the bread bin, getting the 2 slices out, putting it in the plate, buttering it, that's making a sandwich, not the sandwich made.
Yeah.
If you want a deeper experience, then make 1,000 sandwiches.
And notice how you make them.
And notice and what you're doing. Be attentive to making the sandwiches. And every time you do it, it gets better and better and better.
Yeah, because you'll find the most effective way to butter the bread.
Right. If you're attentive to doing it.
Yeah, you know how much butter to each scoop with the knife. And
rather than finish with 10 made sandwiches and observing which one is the best.
Yeah.
That's too late.
Yeah, because that's the end product. You don't know. Okay, that's cool.
Does that make sense?
Yeah, no, definitely.
So when you're examining the patient, as you're examining the patient, be aware of yourself doing the examination, and then as you do more and more, you get better and better and better, and faster and faster and faster. Same as palpation. Rather than measuring your success by how many patients you've examined and how well you examine them, as in the end result. I've done loads of patients' elbows today, and I had a really good result with tennis elbows, or medial epicondylitis, or lateral epicondylitis, or equinome bursitis or something. I made loads of diagnoses today. Yeah, but that doesn't deepen your experience of examination. That's just the end products. Does that make sense?
Yeah.
So to be good at what you do, be attentive to how you're doing it. Same as cardiology, listening to people's hearts and lungs. Listen. You should always have your stethoscopes with you. You should always be using them again and again and again, because it's not about listening for disease, it's about listening to the normal all the time. And be aware of yourself doing the listening. How am I listening to this patient? Not just the end product.
Yeah.
Because you will acquire things over time and through experience, but it tends to be passive. You're just doing it, and over time you expect it, but rather than actively deepening the experience of doing something. Does that make sense?
Yeah.
Good. Right, when's the next patient? 2 o'clock. Break?
Yeah.
Excellent.